Here is audiobook regarding general systemic microbiology and microbiology antimicrobials. Let's start with revision of normal microbiota in different site of body. Do you know? Neonates delivered by C-section have microbiota, similar to skin bacteria, like Staphylococcus epidermidis. Skin is colonized by Staphylococcus epidermidis, likewise the nose is dominated by Staphylococcus epidermidis, sometimes colonized by Staphylococcus aureus. In the oropharynx, throat viridans group Streptococci are abundant. In the dental plaque, the nasty Streptococcus mutans is present, by the way this bug loves sugar. In the colon, the Bacteroides fragilis are more common than Escherichia coli. The women's vagina is colonized by Lactobacillus, sometimes colonized by E. coli and group B strep. Here is some bugs causing foodborne illness. The quick onset, short duration kind food poisoning is exotoxin-mediated, and caused by bacteria like Staphylococcus aureus and Bacillus cereus. Where do you think you get the Bacillus cereus? It is from the reheated rice. Here is mnemonic, food poisoning from reheated rice. B. cereus. B. cereus. Clostridium botulinum toxin found in improperly canned foods, and its spore found in raw honey. Clostridium perfringens are found reheated meat. The coli O157H7 is from undercooked meat, and the fucking Listeria monocytogenes found in deli meats and soft cheeses. Salmonella is famously found in the poultry, meat, and eggs, and the fucking Staphylococcus aureus preformed toxin is present in the meats, mayonnaise, and custard. The Vibrio parahemolyticus and Vibrio vulnificus are found in the raw and undercooked seafood. Just also remember the Vibrio vulnificus can also cause wound infections from contaminated water or shellfish. Here is a list of bugs causing diarrhea. For the bloody diarrhea, some notable causes are listed here. First one causing bloody diarrhea is Campylobacter, which is a comma or S-shaped bacteria that grows at 42 degrees Celsius. Another one is Entamoeba histolytica, which is a protozoan, and causes amoebic dysentery and liver abscesses. Bloody diarrhea is also caused by the enterohemorrhagic E. coli, O157H7, which produces Shiga toxin, and can cause hemolytic uremic syndrome, while enteroinvasive E. coli just invades the colon lining. The non-typhoidal Salmonella also causes bloody diarrhea. It is lactose-negative, motile, and found in poultry and eggs. Shigella, a notable cause of bloody diarrhea, is lactose-negative. One thing that worth remembering regarding this bug is it has a very low infectious dose of about 50, also produces Shiga toxin, and it has human-only reservoir. Yersinia enterocolytica causes daycare outbreaks of bloody diarrhea, which can mimic appendicitis. For this reason infection by this bug is also called pseudoappendicitis. While watery diarrhea is caused by bugs like Clostridioides difficile, which causes pseudomembranous colitis, which is linked to antibiotics and proton pump inhibitor use. Sometimes diarrhea by this bacteria is bloody. Clostridium perfringens, which is also causes of gas gangrene, can also cause watery diarrhea. The watery diarrhea caused by enterotoxigenic E. coli is also called traveler's diarrhea, which produces heat-labile and heat-stable toxins. Some protozoa like Giardia and Cryptosporidium can cause watery diarrhea. Other cause of watery diarrhea is Vibrio cholerae, which is comma-shaped, and causes rice water diarrhea, which is quite voluminous. It is often acquired from infected seafood. Some viruses causing watery diarrhea are norovirus, which is found commonly in developed countries. Rotavirus is declining in incidence due to vaccines. Others are enteric adenovirus. Common causes of pneumonia by specific age group is going to be discussed here. Please follow me closely. In neonates age less than 4 weeks, common causes are group B strep, E. coli, and viruses like RSV. In children from 4 weeks to 18 years, some causes are mycoplasma, chlamydia trachomatis in infants to 3 years, and chlamydia pneumoniae in school-aged. Lastly, streptococcus pneumoniae is also a notable cause in this age group. In adults of 18 to 40 years, causes of pneumonia are Streptococcus pneumoniae, viruses, e.g., flu, mycoplasma, and chlamydia pneumoniae. In adults age group, 40 to 65 years, Streptococcus pneumoniae, H, influenza, and anaerobic bacteria are causes. Viruses can also cause pneumonia in this age group. In elderly, 65+ years, causes of pneumonia are Streptococcus pneumoniae, influenza, anaerobes, and H. influenza. Also gram-negative rods are a culprit. In some special groups, like in those with alcohol overuse, causes of pneumonia are Klebsiella, and anaerobes due to aspiration risk. In those with injection drug use, Strep pneumoniae, and Staph aureus are causes. Aspiration causes infection with anaerobes like Peptostreptococcus, Fusobacterium, Prevotella, and Bacteroids. Atypical pneumonia causes includes Mycoplasma, Chlamydophila, Legionella, and viruses like RSV, CMV, flu, and adenovirus. In cystic fibrosis, common cause of pneumonia are Pseudomonas, S. aureus, S. pneumoniae, and Burkholderia cepacia. In immunocompromised individuals, S. aureus, gram-negative rods, fungi, viruses, and Pneumocystis jirovecii, like in HIV patients, are some causative example of pneumonia. In healthcare-associated setting, causes are S. aureus, Pseudomonas, and other gram-negative rods. Post-viral infection, Strep pneumoniae, Staph aureus, and H. influenza are some causative organism. In patients with COPD, Strep pneumoniae, H. influenza, Moraxella catarrhalis, and Pseudomonas are known to cause pneumonia. Hello listeners, we are going to discuss common causes of meningitis by age group. Are you guys ready? In newborns, from birth to 6 months, the most common causes of meningitis are Group B Streptococcus, E. coli, and Listeria. While in children aged 6 months to 6 years, the common causes include Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza type B, Group B Streptococcus, and enteroviruses. In people aged 6 to 60 years, the causes are mostly Streptococcus pneumoniae, Neisseria meningitidis, enteroviruses, and herpes simplex virus. For those older than 60 years, the common organisms are Streptococcus pneumoniae, Neisseria meningitidis, Listeria, and Group B Streptococcus. Now let's focus on the empiric treatment for meningitis first. Start with ceftriaxone and vancomycin, then if Listeria is suspected, add ampicillin, and if viral encephalitis is suspected, add acyclovir. Among viral causes of meningitis, enteroviruses are the most common, especially Coxsackie. Others include herpes simplex virus type 2, human immunodeficiency virus, West Nile virus, and varicella zoster virus. Remember, herpes simplex virus type 1 more often causes encephalitis, not meningitis. In people with HIV, Cryptococcus is a key cause. Some important notes: due to improved prenatal screening and antibiotic use, Group B Streptococcus meningitis in newborns is now less common, and vaccination has also reduced cases of Haemophilus influenza meningitis, which is now mostly seen in children who haven't been immunized. Cerebrospinal fluid findings in meningitis. For bacterial meningitis, the opening pressure is high, cells are mostly neutrophils, protein is elevated, and glucose is low. For fungal or tuberculosis meningitis, opening pressure is high, cells are mostly lymphocytes, protein is elevated, and glucose is low. For viral meningitis, opening pressure may be normal or slightly high, cells are mostly lymphocytes, and both protein and glucose levels are usually normal or slightly elevated. Now let's talk about causes of brain abscess. The most common organisms are Viridans streptococci and Staphylococcus aureus. Dental infections or procedures can introduce oral anaerobes. Multiple abscesses are typically from bloodstream infections, and single abscesses usually result from nearby infections, like otitis media or mastoiditis can spread to the temporal lobe or cerebellum. Sinus or dental infections often affect the frontal lobe. In AIDS patients, reactivation of toxoplasma is a cause to consider. Osteomyelitis cause may depend by risk factor. Without specific risk factors, assume Staphylococcus aureus is the cause. In sexually active individuals, Neisseria gonorrhoeae is a rare cause but may cause septic arthritis, while in sickle cell disease, common organisms include Salmonella and Staph aureus. With joint replacements, suspect Staph aureus or Staph epidermidis. In spine infections, think of Staph aureus and tuberculosis, also known as pot disease. From animal bites, Pasteurella multicida is common. In injection drug users may get infections from Staph aureus, Pseudomonas, or Candida. Tests like ESR and CRP are sensitive but not specific, and X-rays are not helpful early in the disease but may be useful later. MRI is the best imaging for detecting early osteomyelitis and understanding how far the infection has spread. A biopsy or aspirate with culture is necessary to identify the exact organism. Now let's talk about the red rashes you often see in children, starting with hand, foot and mouth disease, which is caused by Coxsackie type A. This illness shows up as small, oval-shaped blisters on the palms and soles, and at the same time, there are painful vesicles and ulcers inside the mouth, especially on the tongue and inner cheeks. This oral presentation is also known as herpangina. Are you following me? Good. Next is roseola, also called exanthem subitum, caused by human herpes virus type 6. It usually affects infants and begins with several days of high fever, which can even lead to febrile seizures. Then, after the fever breaks, pink, rose-colored spots suddenly appear on the body, and interestingly, the child might otherwise look fine. Now listen carefully, because measles, or rubeola, is another serious one. It starts with a few classic symptoms: cough, coryza, and conjunctivitis, followed by small blue-white spots in the mouth called Koplik spots. Soon after, a deep red, confluent rash appears at the hairline and moves down the body, spreading rapidly. You should remember this. Fifth disease, or erythema infectiosum, is caused by parvovirus B19. The hallmark is a bright red rash on the cheeks that looks like the child was just slapped, hence the name, slapped cheek rash. Now let's switch gears to rubella, also known as German measles, which is caused by the rubella virus. It starts with pink, flat spots and tiny bumps that begin on the face and move down the body, but unlike measles, the rash remains discrete and doesn't merge. You might also notice fine peeling on the trunk and tender swelling behind the ears, especially around the postauricular lymph nodes. Are you ready for the next one? It's scarlet fever, caused by Streptococcus pyogenes, specifically group A strep. The child may first have a sore throat, followed by a distinctive sandpaper-like rash that starts on the neck and spreads to the trunk and limbs. There's often a pale area around the mouth called circumoral pallor, swollen lymph nodes, and a classic red, bumpy tongue, which is why we say scarlet for sore throat, circumoral pallor, group A strep, rash, lymphadenopathy, erythrogenic toxin, and tongue changes. And finally, let's not forget about chickenpox, caused by the varicella-zoster virus. It begins with a vesicular rash starting on the trunk, then spreading to the face and limbs. What makes it unique is that you'll see all kinds of lesions at the same time, some fresh blisters, some crusted scabs, all in various stages of healing. Now that was a lot of red rashes, but trust me, if you remember the key features, you'll recognize them in no time. Alright, are you ready to break down urinary tract infections and vaginal infections? Let's dive right in. First, let's talk about urinary tract infections, starting with cystitis, which commonly shows up with symptoms like burning pain while urinating, that's dysuria, along with increased frequency, urgency, and discomfort right above the pubic bone, also called suprapubic pain. If you check the urine, you'll often see white blood cells, but not white cell casts. This kind of infection usually starts with bacteria traveling upward from the urethra to the bladder. Now listen carefully, if the infection climbs even higher, it can reach the kidneys and cause pyelonephritis, which is more severe. Here, the person might have fever, chills, pain on the side, that's flank pain, tenderness near the back where the kidney lies, blood in the urine, and this time, yes, white cell casts in the urine. UTIs are 10 times more common in females, mostly because their urethras are shorter and more easily colonized by gut bacteria. You should remember this. There are several risk factors that increase the chance of developing UTIs. These include anything that blocks the flow of urine, like kidney stones or an enlarged prostate, recent urinary tract surgeries, catheter use, birth defects in the genitourinary system like vesicoureteral reflux, diabetes, and even pregnancy. Now, let's talk about the culprit bacteria. The number one cause is Escherichia coli, or E. coli, which ferments lactose and turns bright pink on McConkey agar. Diagnostic tests often show a positive leukocyte esterase, which means white cells are active, and a positive nitrite test, because E. coli can convert nitrates to nitrites. Next is Staphylococcus saprophyticus, especially in young, sexually active females. Then we have Klebsiella pneumoniae, which forms thick, gooey colonies thanks to its large mucoid capsule. Serratia marcescens is another player, sometimes making a red pigment and often showing up in hospital settings with drug resistance. Speaking of hospitals, Enterococcus and Pseudomonas aeruginosa are also common in healthcare settings and tough to treat due to resistance. Proteus mirabilis is another interesting one. It's very motile, forms swarming patterns on agar, produces urease, and is associated with struvite kidney stones. Now let's shift gears and talk about common vaginal infections, and trust me, this part is important to understand. First up, bacterial vaginosis. This one usually has no inflammation, but produces a thin, white discharge with a strong fishy smell. On the microscope, you'll see clue cells, which are epithelial cells covered with bacteria. The pH is higher than 4.5, and if you add potassium hydroxide, that fishy odor gets even stronger. That's the positive whiff test. It's usually treated with metronidazole or clindamycin. Are you still with me? Good. Next is Trichomonas vaginitis, caused by a parasite. It comes with inflammation, a frothy yellow-green discharge that smells bad, and the cervix may look red and irritated. We call it a strawberry cervix. Under the microscope, you'll see motile, pear-shaped trichomonads. Like bacterial vaginosis, the pH is above 4.5. Treatment is metronidazole, and here's the catch: you should also treat the sexual partner. Finally, there's Candida vulvovaginitis, which causes inflammation and a thick white discharge that looks like cottage cheese. Unlike the other two, the vaginal pH is normal, between 4.0 and 4.5, and you'll see pseudohyphae under the microscope. The treatment of choice: azole antifungals. And there you have it, a full run-through of UTIs and vaginal infections. Alright, now listen carefully. It's time to explore sexually transmitted infections, or STIs, and we're going to do it in a way that flows and sticks with you. Let's start with AIDS, which results from infection with HIV. This condition weakens the immune system over time, leading to opportunistic infections, certain cancers like Kaposi sarcoma and lymphoma, and if untreated, it becomes life-threatening. Now let's talk about chancroid, which is caused by Haemophilus ducreyi. It presents with painful genital ulcers that often ooze and are accompanied by swollen lymph nodes in the groin. That's called inguinal adenopathy. Just think of it this way: it hurts so much, you do cry. Are you following me? Great, let's move on to chlamydia, which is caused by Chlamydia trachomatis, specifically serotypes D through K. It can cause urethritis, cervicitis, epididymitis, conjunctivitis, and even lead to pelvic inflammatory disease, or PID. Sometimes it triggers reactive arthritis, a condition where your joints get inflamed after the infection. Next, we've got condylomata acuminata, which are genital warts caused by HPV types 6 and 11. These warts are often soft, skin-colored, and contain a distinct type of cell called a koilocyte. Now listen carefully: if you hear someone talk about painful genital vesicles that later turn into ulcers, accompanied by tender lymph nodes on both sides of the groin, plus symptoms like fever, headache, or body aches, they might be dealing with herpes genitalis, which is usually caused by HSV-2, but sometimes HSV-1. Let's not forget gonorrhea, caused by Neisseria gonorrhoeae. It can present as urethritis, cervicitis, epididymitis, PID, prostatitis, or even arthritis. The discharge? Thick, creamy, and purulent, definitely not normal. Are you ready for a lesser-known one? Granuloma inguinal, also called donovanosis, is rare in the US but it presents with a painless, beefy red ulcer that bleeds easily. It's caused by Klebsiella granulomatis, and if you look at it under the microscope, you'll see Donovan bodies, which are intracellular organisms that stain in a unique bipolar pattern. Now let's talk about hepatitis B, which can be transmitted sexually and causes jaundice, that yellowing of the skin and eyes, due to liver inflammation. The virus responsible is simply HBV. Moving on, there's lymphogranuloma venereum, caused by Chlamydia trachomatis again, but this time serotypes L1 through L3. It starts with painless genital ulcers, but progresses to painful lymph node swelling, often forming what's called buboes. You should remember this: syphilis comes in 3 stages, all caused by Treponema pallidum. In the primary stage, you'll see a painless sore called a chancre, along with local lymph node swelling. In secondary syphilis, there's fever, generalized lymphadenopathy, a widespread rash, and condyloma dilata, which are broad, wart-like lesions. In tertiary syphilis, things get serious. It may cause gummas, which are soft, tumor-like growths, or tabes dorsalis, a condition affecting the spinal cord. There's also general paresis, aortitis, and a weird little sign called the Argyll-Robertson pupil, which reacts to accommodation but not to light. Finally, let's end with trichomoniasis, caused by Trichomonas vaginalis. It presents with vaginal irritation, a strawberry cervix, and if you do a wet prep, you'll see motile trichomonads swimming around. Alright, are you guys ready to dive into one of the most important topics? Let's talk about torch infections. These are infections that can pass from a mother to her baby either through the placenta or during vaginal delivery, especially when it comes to HSV-2. Now listen carefully. Although each torch infection is caused by a different microbe, many of them share common features in the newborn. These include an enlarged liver and spleen, which we call hepatosplenomegaly, as well as jaundice, low platelet count, known as thrombocytopenia, and growth restriction, meaning the baby doesn't grow as expected in the womb. But torch isn't the whole story, that pass from mom to baby. There are other culprits that can cause serious trouble in newborns, but not included in torch. These include group B streptococci, which is Streptococcus agalactiae, E. coli, and Listeria monocytogenes, and these 3 can lead to meningitis in neonates. Also, don't forget about parvovirus B19, which can cause a dangerous condition called hydrops fetalis, where the baby develops fluid buildup in multiple compartments. Now let's go through the main torch agents one by one. First up, we have Toxoplasma gondii. A mother can get infected from cat feces or by eating undercooked meat. Most moms don't feel anything, or they may have a little lymph node swelling, but the baby can suffer a classic triad: chorioretinitis, which is inflammation of the eye, hydrocephalus, where fluid builds up in the brain, and intracranial calcifications, which are deposits of calcium in brain tissue. Sometimes, there's also a blueberry muffin rash, which is due to extra blood cell formation outside the bone marrow. Next, let's talk about rubella. It spreads through respiratory droplets, and moms might get a rash, swollen lymph nodes, and joint pain. But the baby? That's where things get serious. The classic triad here is eye problems like cataracts, hearing loss, and heart defects like a patent ductus arteriosus, or PDA. You might also see that same blueberry muffin rash. Here's a trick to remember it: eye heart suit heart ruby rubella earrings. That's eye, heart, and ear abnormalities caused by rubella. Now, here comes cytomegalovirus, or CMV, which can spread through sexual contact or organ transplants. The mom usually has no symptoms or just a mild mono-like illness, but the baby? They might have hearing loss, seizures, chorioretinitis, and those classic, blueberry muffin, spots again. A key difference here is periventricular calcifications, calcium deposits around the brain's ventricles. Here's a little mnemonic: CMV equals chorioretinitis, microcephaly, periventricular calcifications. Moving on to HIV, which spreads through sexual contact or needle stick injuries. The mom's symptoms vary depending on how weak her immune system is, but the baby might have chronic diarrhea and recurrent infections, not good signs in a newborn. Let's not forget herpes simplex virus type 2, or HSV-2. This one spreads during vaginal delivery through direct skin or mucous membrane contact. Moms might not show any signs, or they might get herpetic blisters. The baby, though, can develop meningoencephalitis or those same painful herpetic vesicles. Finally, there's syphilis, caused by Treponema pallidum. If the mom is in the primary stage, she'll have a painless sore, and if she's in the secondary stage, she'll have a widespread rash, and either stage can affect the baby. Syphilis can lead to stillbirth or hydrops fetalis. If the baby survives, you might see notched teeth, a saddle-shaped nose, persistent runny nose, a short upper jaw, bowed shins, and even deafness due to 8th cranial nerve damage. Wow! That was a lot, but now let's test how well you were following. Here comes 3 multiple-choice questions. Question 1. Which torch infection is classically associated with the triad of chorioretinitis, hydrocephalus, and intracranial calcifications? A. Rubella. B. Cytomegalovirus. C. Toxoplasma gondii. D. Syphilis. Answer: C. Toxoplasma gondii is the one with that classic triad. Question 2. A baby is born with a blueberry muffin, rash, cataracts, and a heart murmur due to a PDA. Which maternal infection is the likely cause? A. CMV. B. Rubella. C. HSV-2. D. HIV. Answer: B. Rubella gives us that classic combination of eye, heart, and ear problems. Question 3. Which torch infection is most likely to be transmitted during vaginal delivery, rather than transplacentally? A. Cytomegalovirus. B. HSV-2. C. Toxoplasma gondii. D. Rubella. Answer: B. HSV-2 is typically transmitted during vaginal birth, not across the placenta. Alright folks, are you ready to get into some high-yield, test-worthy, and real-world critical infections? Let's start with pelvic inflammatory disease, or PID for short, a major cause of reproductive health problems in women. So here's the deal: PID is an ascending infection, meaning it moves upward through the female reproductive tract. It can involve salpingitis, which is inflammation of the fallopian tubes, endometritis, meaning the uterine lining is inflamed, hydrosalpinx, where the tubes get filled with fluid, and sometimes even leads to a tubo-ovarian abscess. Now listen carefully, because recognizing it clinically is crucial. One of the hallmark signs is cervical motion tenderness, where moving the cervix during a pelvic exam causes pain. You'll also often find adnexal tenderness, which means tenderness near the ovaries, and purulent cervical discharge, that's thick, yellow, or greenish discharge coming from the cervix. When it comes to causes, the most common bugs are Chlamydia trachomatis, which tends to be subacute and may go undiagnosed for a while, and Neisseria gonorrhoeae, which causes more acute symptoms. Just a quick side note, C. trachomatis is actually the most common bacterial sexually transmitted infection in the U.S. Now here's something you should absolutely remember: salpingitis, one of the main features of PID, is a huge risk factor for ectopic pregnancy, infertility, chronic pelvic pain, and pelvic adhesions. And if the infection spreads up toward the liver, it can cause perihepatitis, also known as Fitzhugh-Curtis syndrome, which is inflammation of the liver capsule. In surgery, you might even see those famous violin string adhesions stretching between the liver and the peritoneum. Wild, right? Now let's switch gears. Are you following me? Let's move into something equally important: healthcare-associated infections, or HAIs. These are infections people get while receiving treatment in a hospital or healthcare setting, and they are a major concern for both patients and providers. One of the top offenders. You guessed it, E. coli, which often causes urinary tract infections, and Staphylococcus aureus, especially the MRSA strain, which is known for infecting surgical wounds. Now, depending on the situation and exposure, different pathogens become more likely. So let's go through some scenarios smoothly. If a patient recently used antibiotics or proton pump inhibitors, they're at risk for Clostridioides difficile, or C. diff, which causes watery diarrhea and high white blood cell counts, that's leukocytosis. What if someone has altered mental status or is elderly and ends up aspirating food or fluids into their lungs? The infection here is usually polymicrobial, meaning multiple types of bugs are involved, especially gram-negative bacteria and anaerobes. The infection often lands in the right lower lobe of the lung, or the right upper and middle lobes if the person was lying down. Expect foul-smelling, purulent sputum. Now let's say a patient has surgical wounds, decubitus ulcers, or drains in place. In these cases, infections are usually caused by Staph aureus, including MRSA, or anaerobic bacteria like Bacteroides, Prevotella, and Fusobacterium. You'll notice redness, tenderness, firm swelling, and drainage from the site. How about infections from intravascular catheters? The culprits here are again Staph aureus and Staph epidermidis, especially in long-term catheter use. Symptoms include redness, swelling, and tenderness around the fore site, along with possible drainage. Mechanical ventilation or endotracheal intubation, especially in the ICU, can lead to late-onset pneumonia. Bugs like Pseudomonas, Klebsiella, Acinetobacter, and again Staph aureus are common here. Watch for a new infiltrate on chest X-ray, an increase in sputum, and if it's Pseudomonas, that sputum may even have a sweet smell. For patients exposed to blood products, shared medical devices, or accidental needle sticks, the concern shifts to hepatitis B and C viruses, so safety protocols are vital. Let's not forget about urinary catheters, which are notorious for introducing bugs like Proteus, E. coli, and Klebsiella, collectively remembered by the acronym PEC. Symptoms may include painful urination, fever, white blood cells in the urine, and flank pain, which could indicate the infection is moving up to the kidneys. And finally, exposure to water aerosols, like from contaminated AC units or showers, can cause Legionella infection. It shows up as pneumonia along with GI issues, like diarrhea, nausea, vomiting, and sometimes neurologic symptoms too. Let's dive into an essential topic, infections that affect unvaccinated children. These bugs are largely preventable with routine immunization, but when vaccines are skipped or delayed, trouble can arise. So, listen carefully as we explore these infections based on how they show up, starting with skin rashes, moving to neurologic signs, and finishing with respiratory symptoms. First up, dermatologic signs, and we're talking rashes here. If the rash begins at the head and moves downward, and you also notice swollen lymph nodes behind the ears, behind the neck, and at the back of the skull, that's a strong clue for rubella virus. It's often mild in children, but in pregnant women, it's dangerous due to its ability to cause congenital defects. Now compare that to measles, which also presents with a rash that begins at the head and spreads downward, but here's the difference: before the rash even shows up, the child typically has a high fever, cough, runny nose, called coryza, red eyes or conjunctivitis, and the classic Koplik spots, which are tiny white lesions on the buccal mucosa. Next, let's move to the neurologic presentations. These are critical and often life-threatening. One major concern is meningitis, especially when the microbe has colonized the nasopharynx. The classic bug here in unvaccinated children is Haemophilus influenza type B, or HIB for short. Thanks to the HIB vaccine, it's much less common now, but when vaccination isn't done, meningitis becomes a real risk. Another viral neurologic illness that we can't ignore is polio, caused by the poliovirus. It can lead to muscle pain, and in more severe cases, flaccid paralysis, where the muscles become limp and weak. And then there's tetanus, caused by Clostridium tetani. The telltale signs are painful muscle spasms, spastic paralysis, and in extreme cases, lockjaw, where the jaw clamps shut, and opisthotonus, which is a severe arching of the back due to muscle contraction. Now let's talk about respiratory infections. Some of these are loud, dramatic, and even life-threatening. A classic one is epiglottitis, also caused by Haemophilus influenza type B. Even though it can affect vaccinated kids in rare cases, it's far more likely in the unvaccinated. You'll see a child with high fever, trouble swallowing, drooling, and stridor, which is a harsh, whistling sound when they breathe in. It's a medical emergency due to the risk of airway obstruction from swelling. Next is pertussis, also known as whooping cough, caused by Bordetella pertussis. This one starts off like a common cold, mild fever and runny nose, then progresses to intense coughing fits, often ending in vomiting after the cough. That's the posttussive vomiting. Recovery can take weeks, hence the nickname, the 100-day cough. And finally, there's diphtheria, caused by Corynebacterium diphtheriae. You'll notice a grayish pseudomembrane in the throat, which can actually block the airway if it gets too large. This is why we stress vaccination, because diphtheria can kill quickly if left untreated. Let's talk about how antibiotics work, shall we? These powerful medicines target different parts of a bacterial cell to stop infections in their tracks. We'll explore 7 major targets. Ready? Let's dive in. First up, folic acid synthesis and reduction. Bacteria can't live without folic acid, they need it to make DNA. Unlike us, who get folate from our diet, bacteria make it from scratch. So here's where we outsmart them. Sulfonamides, like sulfamethoxazole and sulfadiazine, block the first step by preventing the conversion of a molecule called PABA into dihydrofolate, or DHF. Then, trimethoprim blocks the next step, turning DHF into tetrahydrofolate, or THF. When used together, these drugs halt DNA production. That's why they're often combined as TMPSMX, a powerful duo. Second target, DNA integrity, via free radicals. Now let's talk damage. Metronidazole creates free radicals that break apart bacterial DNA. This one's especially good against anaerobic bacteria, those that thrive without oxygen. Third target, mRNA synthesis. Here's a fun fact, no RNA means no proteins. Rifampin blocks RNA polymerase, the enzyme that makes messenger RNA. Without mRNA, the bacteria can't make proteins, and that's the end of the line. Fourth target, DNA gyrase, the untwister of DNA. Moving on, bacteria need a special enzyme called DNA gyrase to unwind their DNA for replication. Fluoroquinolones, like ciprofloxacin, ofloxacin, levofloxacin, and moxifloxacin, block this enzyme. That stops the bacteria from making new DNA, perfect for treating things like urinary and respiratory infections. Fifth target, protein synthesis, the ribosome story. Ribosomes are the protein factories of the cell. They come in 2 pieces, the 50S and 30S subunits. Different antibiotics hit each one in their own way. Let's start with the 50S subunit. We have chloramphenicol, clindamycin, and linezolid. Then come the macrolides, that's azithromycin, clarithromycin, and erythromycin. And don't forget the streptogramins, quinupristin and dalfopristin. Now for the 30S subunit. Here you'll find the aminoglycosides, gentamicin, neomycin, amikacin, tobramycin, and streptomycin. You'll also see the tetracyclines, tetracycline, doxycycline, and minocycline. And finally, tigecycline, a unique glycyl cycline. All of these stop the bacteria from making proteins, and without proteins, there's no survival. Sixth target, the cell wall, the bacterial armor. Let's break this down into 2 parts. First, we have peptidoglycan synthesis, the bricks of the wall. Drugs like vancomycin and bacitracin stop these bricks from being made. Second, we've got peptidoglycan cross-linking, basically the cement that holds the wall together. That's where drugs like penicillin G and V, amoxicillin, and ampicillin come in. For tougher bacteria, we use resistant penicillins, like oxacillin, nafcillin, and dicloxacillin. If you're dealing with harder-to-kill organisms, especially Pseudomonas, you'll need piperacillin. Then we have cephalosporins, which come in 5 generations, from cefazolin to cefepime, and newer ones like ceftaroline. We also have carbapenems, like imipenem, meropenem, and ertapenem, the big guns. And for gram-negative bacteria? Astraeonam, Amonobactam, is your go-to. Seventh target, membrane integrity, popping the bubble. Finally, we reach the outer layer, the membrane. This is where drugs like daptomycin, which works on gram-positives, and polymyxins, which target gram-negatives, come into play. They break the membrane, causing the bacteria to literally fall apart. Recap time. So here's the big picture: antibiotics can block folic acid synthesis, break bacterial DNA, stop mRNA from forming, shut down DNA gyrase, paralyze ribosomes, cripple the cell wall, or pop the membrane altogether. Now you've got a full map of how antibiotics do their job. Let's dive into the world of penicillins, the classic beta-lactam antibiotics. We'll break them down by type, starting with the originals, then working our way up to the advanced versions. Ready? Penicillin G and penicillin V, the prototypes. Penicillin G is given by 4 or IM, while penicillin V is taken orally. These are the original forms of penicillin, and they're still very useful today. How do they work? They're structural mimics of a molecule called diala-diala. This allows them to bind to penicillin-binding proteins, also called transpeptidases. These proteins are crucial for building the bacterial cell wall. By binding to them, penicillin blocks the cross-linking of peptidoglycan in the cell wall, basically stopping the bacteria from reinforcing its structure. On top of that, they trigger autolytic enzymes, causing the bacteria to break itself down. Pretty clever, right? When it comes to clinical use, penicillin G and V are mostly active against gram-positive organisms. That includes Streptococcus pneumoniae, Streptococcus pyogenes, and actinomyces. But they also cover some gram-negative cocci, mainly Neisseria meningitidis, and spirochetes, especially Treponema pallidum, which causes syphilis. They're bactericidal for gram-positive cocci and rods, gram-negative cocci, and spirochetes. However, they are beta-lactamase sensitive, which brings us to resistance. The main way bacteria fight back is by producing beta-lactamase, an enzyme that cleaves the beta-lactam ring. Some bacteria also develop mutations in the penicillin-binding proteins themselves, making it harder for the drug to latch on. Adverse effects. Watch out for hypersensitivity reactions, drug-induced interstitial nephritis, and in some cases, a direct Coombs-positive hemolytic anemia. Penicillinase-sensitive penicillins, amoxicillin and ampicillin. Now let's talk about the aminopenicillins, specifically amoxicillin and ampicillin. These are just like regular penicillin in how they work, but they have a wider spectrum. That said, they're still penicillinase-sensitive, which means they can be broken down by beta-lactamase. To prevent that, they're often combined with clavulanic acid, which protects the beta-lactam ring. Here's a helpful memory trick: aminopenicillins are amped-up penicillin, more powerful, and broader in coverage. Also, between the two, amoxicillin has better oral bioavailability, so it's more easily absorbed when taken by mouth. For clinical use, these drugs are great against a broader range of bacteria. Think HHLPSS, that stands for H. influenza, H. pylori, E. coli, enterococci, Listeria monocytogenes, Proteus mirabilis, Salmonella, and Shigella. And yes, they're great for treating enterococcus infections too. Common side effects include hypersensitivity reactions, skin rash, and pseudomembranous colitis, which is often linked to Clostridioides difficile overgrowth. As for resistance, again it comes down to penicillinase, which cleaves the beta-lactam ring and makes the drug ineffective. Penicillinase-resistant penicillins, dicloxacillin, nafcillin, oxacillin. Now let's move on to penicillins that are built to resist beta-lactamase. These include dicloxacillin, nafcillin, and oxacillin. How do they resist beta-lactamase? They have a bulky R group that physically blocks the enzyme from accessing the beta-lactam ring. That makes them ideal for bacteria that produce this enzyme. Their narrow spectrum, but they shine when it comes to Staphylococcus aureus, except for MRSA. Just remember this phrase, use NAF for staph. Adverse effects include hypersensitivity reactions and interstitial nephritis. In terms of resistance, MRSA, or methicillin-resistant Staph aureus, uses a different trick. It alters its penicillin-binding proteins, so the drug can't bind and do its job. Antipseudomonal penicillins, piperacillin. Last but not least, we've got piperacillin, a powerful penicillin used for tougher bugs. It works the same way as other penicillins, by blocking peptidoglycan cross-linking, but it has an extended spectrum. It's especially good for Pseudomonas species, as well as gram-negative rods and anaerobes. Like aminopenicillins, piperacillin is penicillinase sensitive, so it's often paired with beta-lactamase inhibitors. Side effects. The usual suspects, hypersensitivity reactions. Alright, let's keep going with the beta-lactam antibiotics, and this time, we're talking about cephalosporins, a powerful family of drugs that target the bacterial cell wall, just like penicillins, but with some unique strengths. So, how do they work? Cephalosporins inhibit cell wall synthesis by blocking transpeptidase enzymes, making them bactericidal. And here's a key point, they're less susceptible to penicillinases, which gives them an edge over standard penicillins in many cases. But keep in mind, there are some bugs they generally don't touch, we call them the lame organisms, that's Listeria, atypicals like chlamydia and mycoplasma, MRSA, with one exception, and enterococci. First generation, cefazolin and cephalexin. These first-gen drugs mainly cover gram-positive cocci, along with a few gram-negatives like Proteus mirabilis, E. coli, and Klebsiella pneumoniae. A handy mnemonic? PEC, that's Proteus, E. coli, and Klebsiella. Now listen carefully, cefazolin is often used before surgery to prevent Staph aureus wound infections. Think of it as a surgical shield. Second generation, cefaclor, cefoxidin, cefuroxime, and cefotetin. These have a little broader coverage. They still hit the gram-positive cocci, but now they also take on H. influenza, Enterobacter, Neisseria, and a few more gram-negatives like Serratia, Proteus, E. coli, and Klebsiella. Remember this fun mnemonic, second graders wear fake fox fur to tea parties. That's cefaclor, fake, cefoxidin, fox, and cefotetin, T. To summarize, second-gen cephalosporins cover hen's peck, that's H. influenza, Enterobacter, Neisseria, Serratia, plus the peck organisms. Third generation, ceftriaxone, ceftazidime, cefpodoxime, and cefixime. Now we're getting serious. Third-gen cephalosporins are reserved for more resistant gram-negative infections, and they can even cross the blood-brain barrier, which makes them excellent for central nervous system infections. Ceftriaxone is a go-to for meningitis, gonorrhea, and disseminated Lyme disease. Ceftazidime, on the other hand, has good coverage for Pseudomonas, a tricky bug that many antibiotics struggle to handle. Fourth generation, cefepime. Fourth-gen cephalosporins like cefepime offer broad coverage, they work against gram-negative organisms, including Pseudomonas, while still maintaining some action against gram-positives. A solid choice when you need strong and wide-spectrum protection. Fifth generation, ceftaroline. Now here's where things get interesting. Ceftaroline, a fifth-generation cephalosporin, is unique because it can actually cover MRSA and even Enterococcus faecalis, something earlier generations couldn't do. But keep in mind, despite its strength, it does not cover Pseudomonas. So be sure to choose wisely based on the bug you're targeting. Side effects, what to watch out for. Like other beta-lactams, cephalosporins can cause hypersensitivity reactions. You might also see autoimmune hemolytic anemia, or a disulfiram-like reaction, especially if taken with alcohol. Some patients might develop vitamin K deficiency, leading to bleeding issues. And while there's a low rate of cross-reactivity with penicillin allergies, it's still something to keep in mind. Also, if used alongside aminoglycosides, there's an increased risk of nephrotoxicity, so kidney function should be monitored. Resistance mechanisms, how bugs fight back. Resistance can happen when bacteria produce cephalosporinases, a type of beta-lactamase that destroys the drug. Alternatively, they might alter their penicillin-binding proteins, making it harder for cephalosporins to latch on and do their job. Beta-lactamase inhibitors, the bodyguards. Sometimes, we call in beta-lactamase inhibitors to protect our antibiotics from destruction. These include clavulanic acid, avibactam, sulbactam, and tazobactam. To help you remember, just think CAST. Clavulanic acid, avibactam, sulbactam, tazobactam. These are often paired with penicillins and even some cephalosporins, like amoxicillin clavulanate, ceftazidime avibactam, ampicillin sulbactam, and piperacillin tazobactam. And there you have it, the full lineup of cephalosporins, how they work, what they treat, and how bacteria fight back. Smooth, powerful, and easy to remember. Alright, are you ready to dive into some of the strongest antibiotics out there? Let's talk about the carbapenems, like imipenem, meropenem, and ertapenem. These are part of the beta-lactam family, and they're known for being broad-spectrum and resistant to beta-lactamases, which means they don't get easily destroyed by common bacterial enzymes. Now here's the cool part, imipenem binds to penicillin-binding proteins, blocks cell wall synthesis, and ultimately causes bacterial cell death. But, there's a catch. On its own, imipenem gets broken down by an enzyme in the kidney called dehydropeptidase I, so it's always given along with cilastatin, which blocks that enzyme. That's why we say, the kill is lost in with cilastatin. Now listen carefully, unlike the others, ertapenem does not work against Pseudomonas, which limits its spectrum a bit. On the other hand, meropenem is special because it has a lower risk of causing seizures and it's also stable to dehydropeptidase I, so it can be used alone in many cases. These drugs cover a wide range, gram-positive cocci, gram-negative rods, and anaerobes, but because of their potential side effects, they're usually reserved for life-threatening infections or when other antibiotics fail. Speaking of side effects, you should remember that carbapenems can cause GI upset, rash, and at high levels in the blood, they can trigger CNS toxicity, especially seizures. As for resistance, some bacteria like Klebsiella pneumoniae, E. coli, and Klebsiella aerogenes produce carbapenemases, enzymes that can inactivate these powerful drugs, and that's a growing concern in clinical settings. Now let's move on to aztreonam, a monobactam antibiotic that's a bit of a loner but incredibly useful. It's less affected by beta-lactamases and works by binding to penicillin-binding protein 3, which prevents cross-linking of peptidoglycan in the bacterial cell wall. What makes aztreonam unique is that it only targets gram-negative rods, and it has no activity against gram-positive organisms or anaerobes. It's often used in patients who are allergic to penicillins or have renal issues, who cannot tolerate aminoglycosides. As for side effects, it's generally very well tolerated, though a little GI upset might occur from time to time. Now, are you following me? Because next up is a big player, vancomycin. Unlike beta-lactams, vancomycin inhibits cell wall synthesis by binding directly to the diala portion of the cell wall precursors. This blocks the bacterial enzymes from building the cell wall properly, leading to cell death. It's bactericidal for most bugs, but interestingly, it's only bacteriostatic against Clostridioides difficile. Also, it's not susceptible to beta-lactamases, which makes it super useful in resistant infections. You should remember this, vancomycin is strictly for gram-positive organisms, and it's especially helpful for treating multi-drug-resistant strains like MRSA, Staphylococcus epidermidis, sensitive Enterococcus species, and C. difficile, particularly when taken orally. Now let's talk side effects. Vancomycin is generally safe, but it's not trouble-free. It can cause nephrotoxicity, ototoxicity, and thrombophlebitis. One classic reaction is the vancomycin infusion reaction, formerly called red man syndrome. It's a flushing response due to histamine release, but it's preventable if you infuse it slowly and give antihistamines beforehand. There's also a rare but serious immune reaction called DRESS syndrome, which includes rash and systemic symptoms. Finally, when it comes to resistance, vancomycin can be outsmarted by some bacteria like Enterococcus, which change the target from diala to diala. That little tweak prevents vancomycin from binding effectively. Just remember the phrase, if you lack a Democrat Alabama, you can't ride the van. Alright, let's break this down. Protein synthesis inhibitors are a class of antibiotics that specifically target bacterial ribosomes, which are smaller and structured differently from human ribosomes. Bacteria have what's called a 70S ribosome, made of two subunits, the 30S and 50S, while humans have an 80S ribosome. That difference is what makes these drugs effective against bacteria without harming our own cells. Now, listen carefully, most of these antibiotics are bacteriostatic, meaning they stop bacteria from growing rather than killing them outright. But there are some exceptions. Aminoglycosides are bactericidal, meaning they kill bacteria directly, and linezolid can be either bacteriostatic or bactericidal depending on the organism. Are you following? Great, because here's an easy way to remember how these drugs work. We say, buy at 30, sell at 50. That means aminoglycosides and tetracyclines act on the 30S subunit, while chloramphenicol, clindamycin, erythromycin, and other macrolides, and linezolid target the 50S subunit. Each of these blocks a different step in the protein-making process: initiation, elongation, translocation, or termination. Now let's zoom in on aminoglycosides. These include gentamicin, neomycin, amikacin, tobramycin, and streptomycin. There's a fun way to remember this group. We say, mean gnats can't kill anaerobes, where NAT stands for the drug names. Why can't they kill anaerobes? Because aminoglycosides require oxygen for cellular uptake, so they're ineffective against anaerobic bacteria. Mechanism-wise, they irreversibly bind to the 30S subunit, which messes up the initiation of protein synthesis. They also cause misreading of mRNA, and block translocation, all of which leads to bacterial death. That's why they're bactericidal. Now let's talk clinical use. Aminoglycosides are mainly used for severe gram-negative rod infections, and they work even better when combined with beta-lactam antibiotics, which help them get inside the bacterial cell. As for neomycin, it's often used to prep the gut before bowel surgery. But, like all powerful drugs, there are some drawbacks. The adverse effects include nephrotoxicity, which means kidney damage, and ototoxicity, especially when taken with loop diuretics. They can also cause neuromuscular blockade, which is why they're absolutely contraindicated in conditions like myasthenia gravis, and they are teratogenic, so they should be avoided in pregnancy. And finally, how do bacteria fight back? Well, resistance to aminoglycosides happens when bacteria produce transferase enzymes that modify the drug, either by acetylation, phosphorylation, or adenylation, which inactivates it and prevents it from working. Alright friends, let's dive into tetracyclines. That includes tetracycline, doxycycline, and minocycline. These antibiotics are bacteriostatic, meaning they stop bacteria from growing by binding to the 30S ribosomal subunit, where they prevent the attachment of aminoacyl tRNA. This basically halts protein production. They don't get into the brain much, so central nervous system penetration is limited. But here's something special about doxycycline: it's eliminated through the feces, not the kidneys, which makes it a great option for patients with renal failure. Now listen carefully, when taking tetracyclines, you should avoid consuming them with milk, antacids, or iron supplements. Why? Because these contain divalent cations like calcium and magnesium, which block the drug's absorption in your gut, making it less effective. Clinically, tetracyclines are used to treat infections like Borrelia burgdorferi, which causes Lyme disease, and Mycoplasma pneumoniae. Thanks to their ability to accumulate inside cells, they're also very effective against rickettsia and chlamydia. And yes, they're even used for acne treatment. One more thing, doxycycline works against community-acquired MRSA, which makes it a real powerhouse. But, like every drug, there are side effects. You might experience gastrointestinal distress, and in children, there's a risk of tooth discoloration and inhibited bone growth. These drugs can also cause photosensitivity, and tetracyclines are teratogenic, so they are generally avoided in pregnancy and in young children, with the exception of doxycycline in some cases. Now, let's talk about resistance. Bacteria can develop resistance to tetracyclines by reducing drug uptake or by pumping the drug out, using plasmid-encoded transport proteins. Pretty clever, right? Are you still with me? Good. Now, let's move on to tigecycline. This one is a derivative of tetracycline, and it works by binding to the 30S subunit, just like its cousins. It's bacteriostatic and covers a broad spectrum, including anaerobes, gram-negative, and gram-positive bacteria, and it's particularly useful for multi-drug-resistant infections, like those caused by MRSA and VRE. The most common side effects are nausea and vomiting, but overall, it's a valuable option when resistance is a concern. Now let's shift gears and talk about chloramphenicol. This one works a bit differently. It blocks the peptidyltransferase activity at the 50S ribosomal subunit, which also stops protein synthesis, making it bacteriostatic. It's used for serious infections like meningitis caused by H. influenza, Neisseria meningitidis, or Streptococcus pneumoniae, and also for rickettsial infections, such as Rocky Mountain spotted fever. Here's the catch: although it's still used in some developing countries due to its low cost, chloramphenicol can have some nasty side effects. It can cause dose-dependent anemia, and dose-independent aplastic anemia, and in premature infants, it can lead to something called gray baby syndrome, due to immature liver enzymes. So, it's not a first-line choice in many places. And resistance? It happens through acetylation by a plasmid-encoded enzyme, which inactivates the drug. Now, are you ready for the last one in this set? Let's talk about clindamycin. This drug blocks peptide translocation at the 50S ribosomal subunit, and it's bacteriostatic as well. Clindamycin is great for anaerobic infections, such as those caused by Bacteroid species and Clostridium perfringens, especially in cases like aspiration pneumonia, lung abscesses, and oral infections. It's also effective against invasive group of streptococcal infections. Here's an easy way to remember its use. Clindamycin treats anaerobic infections above the diaphragm, while metronidazole handles those below. But be cautious, clindamycin is notorious for causing pseudomembranous colitis, which is an overgrowth of C. difficile, leading to severe diarrhea and inflammation. Other side effects include fever and diarrhea. Now listen carefully, let's talk about linezolid. This powerful antibiotic works by inhibiting protein synthesis, and it does so in a unique way. By binding to the 23S ribosomal RNA within the 50S subunit, it blocks the formation of the initiation complex, which is the very first step in assembling the machinery needed for bacterial protein production. Clinically, linezolid is used to treat gram-positive bacteria, including serious infections like MRSA and vancomycin-resistant enterococcus, or VRE. But you should remember this: linezolid is not without side effects. It can cause myelosuppression, especially thrombocytopenia, which means your platelet count can drop. It may also lead to peripheral neuropathy, which shows up as numbness or tingling, and in rare cases, it can trigger serotonin syndrome, especially if taken with other serotonergic drugs, due to its mild MAO inhibition. As for resistance, it usually happens due to a point mutation in the ribosomal RNA, which prevents the drug from binding properly. Clever little microbes, right? Are you guys ready for the next group? Let's move on to the macrolides. These include azithromycin, clarithromycin, and erythromycin. Macrolides work by inhibiting protein synthesis too, but they do it by blocking translocation, that's the movement of the growing protein chain, by binding to the 50S subunit of the ribosome. Because of this, they're considered bacteriostatic, not bactericidal. A nice way to remember it. Think of them as macroslides, because they slide into place and block that movement. Clinically, macrolides are used for a wide range of conditions, including atypical pneumonias caused by mycoplasma, chlamydia, or legionella, and for sexually transmitted infections like chlamydia. They're also useful for gram-positive cocci, especially in patients allergic to penicillin, and they're often given for Bordetella pertussis, which causes whooping cough. Now, here's something you should remember: the major side effects of macrolides can be remembered using the acronym MACRO. That's motility issues in the gut, arrhythmias due to prolonged QT interval, cholestatic hepatitis, rash, and eosinophilia. They can also increase the levels of drugs like theophylline and oral anticoagulants in your blood. Also, clarithromycin and erythromycin are known to inhibit cytochrome P450, which means they can interfere with the metabolism of other medications. Resistance to macrolides usually develops through methylation of the 23S rRNA binding site, which prevents the drug from latching on. Sneaky, right? Alright, last one for now, let's talk about polymyxins, including colistin, also known as polymyxin E, and polymyxin B. These are cationic polypeptides, meaning they have a positive charge, and they work by binding to phospholipids in the outer membrane of gram-negative bacteria. This action disrupts membrane integrity, causes leakage of cellular contents, and eventually leads to bacterial death. Polymyxins are considered salvage therapy. That means they're used when all else fails, especially for multi-drug-resistant gram-negative infections like those caused by Pseudomonas aeruginosa, E. coli, or Klebsiella pneumoniae. On the other hand, polymyxin B is used more locally, as part of triple antibiotic ointments for treating superficial skin infections. But here's the caution: polymyxins are quite toxic. They can cause nephrotoxicity, which harms the kidneys, and neurotoxicity, which may include symptoms like slurred speech, muscle weakness, and tingling or numbness. In severe cases, they can even cause respiratory failure. Alright folks, let's start with sulfonamides, including sulfamethoxazole, sulfasoxazole, and sulfadiazine. These drugs are bacteriostatic on their own, which means they stop bacteria from multiplying, but, when you combine them with trimethoprim, they actually become bactericidal, meaning they can kill the bacteria outright. Now, how do they work? Sulfonamides inhibit an enzyme called dihydropteroate synthase, which is crucial for the synthesis of folate, and folate is something bacteria can't live without. Humans, by the way, don't make folate, we get it from food, so that's why these drugs can selectively target bacteria. Clinically, sulfonamides are used for both gram-positive and gram-negative bacteria, and also for nocardia infections. The combination drug TMPSMX, or trimethoprim sulfamethoxazole, is a go-to treatment for simple urinary tract infections. But you should remember this: sulfonamides have a long list of possible side effects. These include Stevens-Johnson syndrome, which is a serious skin reaction, as well as urticaria, or hives, liver damage, folate deficiency, optic neuritis, nephrotoxicity, agranulocytosis, and hemolysis, especially in patients with G6PD deficiency. It can also cause kernicterus in infants, that's a type of brain damage due to bilirubin buildup, so avoid it in newborns. When it comes to resistance, bacteria can adapt by altering the target enzyme, reducing uptake of the drug, or by increasing their production of PABA, which is the molecule that competes with the drug. Now let's move on to dapsone. Are you following me? Dapsone works in a similar way to sulfonamides, but it's structurally different. That means it's not a sulfonamide, but it still blocks folate synthesis. Clinically, dapsone is a key treatment for leprosy, both the lepromatous and tuberculoid forms, and it's also used for pneumocystis jirovecii pneumonia, especially for prophylaxis or when used alongside trimethoprim. Side effects. You guessed it, dapsone can also cause hemolysis in people with G6PD deficiency, as well as methemoglobinemia, which makes it harder for your blood to carry oxygen, and agranulocytosis, where your white blood cell count drops dangerously low. Now let's finish strong with trimethoprim. This drug inhibits bacterial dihydrofolate reductase, which is the enzyme that comes after the 1-sulfonamides block. So together, they create a sequential block in the folate synthesis pathway, hitting the bacteria at 2 key steps and making the combo very effective. This combination, TMPSMX, is used for urinary tract infections, Shigella, Salmonella, Pneumocystis jirovecii pneumonia, both for treatment and prevention, and also for toxoplasmosis prophylaxis. But here's a clinical pearl: trimethoprim can cause hyperkalemia, especially at high doses, and that's due to its similarity to potassium-sparing diuretics. It can also lead to megaloblastic anemia, leukopenia, and granulocytopenia, but the good news is, these can often be prevented by giving leucovorin, also called folinic acid. And to help you remember the bone marrow side effects, just say, TMP treats marrow poorly. Alright, ready to keep learning? Let's talk about fluoroquinolones, like ciprofloxacin, ofloxacin, and the so-called respiratory fluoroquinolones, which include levofloxacin and moxifloxacin. These drugs are bactericidal, meaning they actively kill bacteria, and they work by inhibiting topoisomerase II, also known as DNA gyrase, as well as topoisomerase IV, enzymes that bacteria use to unwind and replicate their DNA. If they can't do that, they can't survive. One important tip: don't take fluoroquinolones with milk, antacids, or iron. Why? Because these contain divalent cations like calcium and magnesium, which block the drug's absorption in the gut. Clinically, fluoroquinolones are powerful tools. They're great for treating gram-negative rods in the urinary and GI tracts, including tough bugs like Pseudomonas. They also work for some gram-positive bacteria, otitis externa, and even community-acquired pneumonia. Now, side effects: most commonly, patients might experience GI upset, skin rashes, headaches, dizziness, or even superinfections. Occasionally, people report leg cramps and muscle pain. But here's the caution: fluoroquinolones are contraindicated in pregnant women, breastfeeding mothers, and children under 18, due to concerns about cartilage damage. They may also prolong the QT interval, which affects heart rhythm. Another serious risk: they can cause tendinitis or even tendon rupture, especially in people over 60 or those taking prednisone. And keep in mind, ciprofloxacin is a cytochrome P450 inhibitor, so it can interact with other drugs. A simple way to remember it: fluoroquinolones hurt attachments to your bones. Now, let's switch gears and talk about daptomycin. This is a lipopeptide antibiotic that works by creating holes in the cell membranes of gram-positive cocci, leading to cell death. Clinically, it's used for serious gram-positive infections like MRSA, skin infections, bacteremia, infective endocarditis, and VRE, that's vancomycin-resistant enterococci. But there's one key exception: never use daptomycin for pneumonia, because it gets inactivated by lung surfactant. Side effects: mainly muscle-related issues. It can cause myopathy and even rhabdomyolysis, which is serious muscle breakdown. So think of it this way: daptomyoskin, it works on skin, but watch for muscle pain. Finally, let's talk about metronidazole, an important antibiotic and antiprotozoal. This drug forms free radicals inside the microbial cell, which then damage the DNA and kill the organism. It's bactericidal and works well against anaerobes and protozoa. We use metronidazole for infections like Giardia, Entamoeba histolytica, Trichomonas, Gardnerella vaginalis, and Clostridium difficile. It's also an option in H. pylori triple therapy, especially if the patient is allergic to penicillin. Now here's a memory tip: get GAP on the metro with metronidazole: G for Giardia, E for Entamoeba, T for Trichomonas, G for Gardnerella, A for anaerobes, and P for pylori. Another pearl: metronidazole is preferred for anaerobic infections below the diaphragm, while clindamycin is better for those above. And the side effects? It can cause a disulfiram-like reaction if taken with alcohol. That means severe flushing, a rapid heartbeat, and low blood pressure. Patients might also report headaches and a metallic taste in their mouth. Are you ready to tackle the main drugs used to treat tuberculosis? Let's break down the first-line antituberculous agents, including rifamycins, isoniazid, pyrazinamide, and ethambutol, in a way that's easy to remember. Let's start with the rifamycins. This group includes rifampin, rifabutin, and rifapentine. These drugs inhibit DNA-dependent RNA polymerase, which stops the production of messenger RNA. And when bacteria can't make mRNA, they can't make proteins, and that means they can't survive. Rifamycins are useful, but resistance can happen quickly. Why? Because mutations in the RNA polymerase gene can prevent the drug from binding properly. Side effects. They can cause minor liver toxicity, and they're known for interacting with many other drugs because they induce cytochrome P450 enzymes. But here's something unusual: they can also cause red-orange discoloration of body fluids, like urine, tears, and sweat. It looks dramatic, but it's harmless. Here's a tip: rifabutin is preferred in patients with HIV, because it induces less CYP450, reducing drug interactions with antiretrovirals. Also remember, never use rifamycins alone, because monotherapy quickly leads to resistance. Now let's talk about isoniazid, often abbreviated as INH. It works by inhibiting mycolic acid synthesis, which is essential for building the mycobacterial cell wall. But there's a catch: the drug must first be activated by an enzyme called catalase peroxidase, which is produced by the CatG gene in the bacterium. If this gene mutates, resistance can develop. Side effects. There are several. INH can cause vitamin B6 deficiency, leading to peripheral neuropathy and sideroblastic anemia. It can also cause hepatotoxicity, CYP450 interactions, and even drug-induced lupus. In overdoses, seizures may occur, and they're often hard to treat with standard medications like benzodiazepines. That's why we always give INH with vitamin B6, also called pyridoxine. Here's a mnemonic: INH injures neurons and hepatocytes, and the risk goes up with age and alcohol use. One last note: people metabolize INH differently. Some are fast acetylators, others are slow, and that affects drug levels in the body. Let's continue with pyrazinamide. Its exact mechanism is still unclear, but we do know it works best in acidic environments, like inside host phagocytomes, where TB bacteria often hide. Side effects include hepatotoxicity and hyperuricemia, which means high uric acid levels in the blood. This could potentially trigger gout. Now for the last one, ethambutol. It works by inhibiting arabinoacyltransferase, an enzyme involved in arabinogalactan synthesis, which is also a key component of the mycobacterial cell wall. Its main side effect is optic neuropathy, which might cause blurred vision, loss of visual acuity, or red-green color blindness. Fortunately, these effects are usually reversible if the drug is stopped. What a fun way to remember it. Think of ethambutol: it affects your eyes. To summarize, here's how each drug targets TB. Rifamycins block mRNA synthesis. Isoniazid blocks mycolic acid synthesis. Pyrazinamide works intracellularly, though its mechanism is unclear. Ethambutol blocks arabinogalactan synthesis, which is part of the cell wall. Each one hits a different target, which is why combination therapy is so important in tuberculosis. It prevents resistance and ensures all angles are covered. Alright, are you ready? Let's talk about antimicrobial therapy and how we approach both prophylaxis and treatment across different bacterial infections. For Mycobacterium tuberculosis, the recommended prophylaxis is a rifamycin-based regimen that lasts about 3 to 4 months, and when it comes to treatment, we use the RIPE combination, which includes rifampin, isoniazid, pyrazinamide, and ethambutol. Moving on to Mycobacterium avium, intracellular, prophylaxis includes azithromycin or rifabutin, while treatment typically involves azithromycin or clarithromycin combined with ethambutol, and in some cases, rifabutin or ciprofloxacin can be added. Now listen carefully: for Mycobacterium leprae, there's no standard prophylaxis, but treatment depends on the form. Tuberculoid leprosy is managed with long-term dapsone and rifampin, while the lepromatous form adds clofazimine to the regimen. Now let's talk about general antimicrobial prophylaxis based on specific clinical scenarios. If someone has been exposed to meningococcal infection, we can give ceftriaxone, ciprofloxacin, or rifampin. For patients who are at high risk of infective endocarditis and are about to undergo a surgical or dental procedure, amoxicillin is typically used. When someone has a history of recurrent urinary tract infections, TMPSMX is a common choice. Are you following me? For malaria prevention in travelers, depending on the region and resistance patterns, options include atovaquone proguanil, mefloquine, doxycycline, primaquine, or chloroquine. Now listen carefully. For pregnant women who are carrying group B streptococcus, we prevent neonatal infection by giving intrapartum penicillin G or ampicillin. To prevent gonococcal conjunctivitis in newborns, we apply erythromycin ointment directly to the eyes. When we want to prevent post-surgical infections caused by Staphylococcus aureus, we often give cefazolin, but if the patient is known to be colonized with MRSA, vancomycin is preferred. And you should remember this: children with a history of rheumatic fever need to be protected from strep pharyngitis, and for that, we use benzathine penicillin G or oral penicillin V. Finally, let's wrap up with prophylaxis in HIV or AIDS patients. If their CD4+ count falls below 200 cells per cubic millimeter, TMPSMX is given to prevent pneumocystis pneumonia. And if that count drops even further, below 100, we still give TMPSMX, but now to prevent both pneumocystis pneumonia and toxoplasmosis. Perfect. Now listen carefully as we dive into antifungal therapy, especially the mechanisms and uses of some key antifungal agents. Let's start with amphotericin B. This drug works by binding to ergosterol, which is unique to fungal membranes, and it forms pores that let electrolytes leak out, essentially, tearing holes in the fungus. Yes, think of it as amphotericin tearing the membrane. It's used to treat serious, systemic fungal infections like cryptococcal meningitis, especially when combined with flucytosine, and also for infections caused by blastomyces, coccidioids, histoplasma, candida, and even mucor. For coccidioidal meningitis, it's sometimes given intrathecally. Now, because this drug messes with renal tubule permeability, potassium and magnesium supplementation is often needed. But be careful, because side effects include fever and chills, what people call shake and bake, along with hypotension, nephrotoxicity, arrhythmias, anemia, and inflammation at the fore site, which is why it's sometimes nicknamed amphoterrible. Hydrating the patient helps reduce kidney damage, and using a liposomal formulation can reduce toxicity. Now let's talk about nystatin. It works just like amphotericin B, same mechanism, binds ergosterol and forms pores, but it's far too toxic to be used systemically. That's why it's only used topically. You'll often hear it recommended as a swish and swallow treatment for oral candidiasis, and it's also used for diaper rash and vaginal yeast infections. Now listen carefully, because flucytosine has a very different mechanism. Once inside fungal cells, it's converted into 5-fluorouracil by the enzyme cytosine deaminase. This toxic metabolite then inhibits DNA and RNA synthesis. It's used mostly in combination with amphotericin B for systemic fungal infections, especially cryptococcal meningitis. One key adverse effect you should watch out for is myelosuppression, which means it can suppress bone marrow function and reduce blood cell production. Are you following me? If you're ready, we can keep going with azoles, echinocandins, or terbinafine next. Now listen carefully. We'll start with azoles, a group that includes clotrimazole, fluconazole, isovuconazole, itraconazole, ketoconazole, miconazole, and voriconazole. These drugs work by inhibiting the fungal enzyme cytochrome P450, which normally converts lanosterol into ergosterol, an essential component of the fungal cell membrane. Without ergosterol, the fungus can't maintain its structure. Clinically, azoles are used for both local and mild systemic infections. Fluconazole is great for suppressing cryptococcal meningitis in people living with HIV, and it's effective against all types of candidal infections. Itraconazole is preferred for infections like blastomyces, coccidioids, histoplasma, and Sporothrix skenki. Clotrimazole and miconazole are ideal for topical infections. Voriconazole is used for aspergillus and certain candida infections, while isovuconazole is reserved for more severe aspergillus and mucor infections. Now, side effects can include testosterone synthesis inhibition, leading to gynecomastia especially with ketoconazole, along with liver dysfunction due to P450 inhibition, and prolonged QT interval. Now let's talk about terbinafine. This antifungal inhibits the fungal enzyme squalene epoxidase, disrupting ergosterol synthesis early in the pathway. It's especially useful for dermatophytoses, and more specifically onychomycosis, which is a fungal infection of the nails. But you should be aware, it can cause gastrointestinal upset, headaches, liver toxicity, and changes in taste perception. Are you following me? Good, because now we'll look at echinocandins, which include anidulafungin, caspofungin, and micafungin. These drugs inhibit synthesis of beta-glucan, an essential component of the fungal cell wall. Clinically, they're used for invasive aspergillosis and candida infections. And while they're generally well tolerated, they can cause GI upset and flushing due to histamine release. Now listen carefully, because griseofulvin is a bit different. It interferes with microtubule function and disrupts mitosis, and it gets deposited in keratin-containing tissues like nails. That's why it's used orally to treat superficial fungal infections caused by dermatophytes, such as tinea and ringworm. However, it's not without risks. It can be teratogenic, and even carcinogenic in rare cases. Side effects include confusion, headaches, and a disulfiram-like reaction with alcohol. It also revs up cytochrome P450, which can mess with the metabolism of other drugs like warfarin. Are you ready to move into antiparasitic territory? Let's go. Antiprotozoal therapy includes drugs like pyrimethamine sulfadiazine for toxoplasmosis, suramine and melarsoprol for Trypanosoma brucei, nifurtimox for Trypanosoma cruzi, and sodium stibogluconate for leishmaniasis. And when it comes to antimite and louse therapy, we rely on permethrin, malathion, which is an acetylcholinesterase inhibitor, and either topical or oral ivermectin. These are used to treat infestations caused by scabies, or Sarcoptes scabii, and lice, which include both pediculus and tyrus species. Now, let's finish up with chloroquine, a classic antimalarial. It works by blocking the detoxification of heme into hemazoin, and the accumulated heme becomes toxic to the plasmodium. It's effective for all plasmodial species except Plasmodium falciparum, because of its resistance through a membrane pump that reduces drug accumulation inside the parasite. Adverse effects include retinopathy, which depends on the total cumulative dose, and pruritus, especially in people with dark skin. Let's start with antihelminthic therapy, which is used to treat parasitic worm infections. Some key drugs include pyrantel pamoate, ivermectin, mebendazole, praziquantel, and diethylcarbamazine. Mebendazole works by disrupting microtubules and cellular movement. Think of it as stopping the worms from bending and moving. Praziquantel increases calcium permeability in the worm's membrane, which leads to muscle contraction and vacuolization, ultimately paralyzing and killing the parasite. Now let's talk about some antiviral drugs, starting with oseltamivir and zanamivir. These two inhibit the influenza neuraminidase enzyme, which is responsible for releasing new virus particles from infected cells. Clinically, they are used to treat and prevent both influenza A and B, but you need to act fast. Starting treatment within 48 hours of symptom onset can shorten the duration of illness significantly. Are you following me? Great, because next up is baloxavir. It works by inhibiting an enzyme used by the influenza virus called endonuclease, which is part of a process known as cap snatching. This mechanism allows the virus to hijack the host cell's mRNA caps for its own replication. Like oseltamivir, it works best when started within 48 hours of symptoms. Now listen carefully, remdesivir is a drug that gained attention recently. It's a prodrug, which means it needs to be activated inside the body. Once active, it mimics ATP and inhibits viral RNA-dependent RNA polymerase, the enzyme the virus uses to copy its genetic material. It also evades viral proofreading by a protein called X-ribonuclease. Remdesivir has been approved for the treatment of COVID-19, particularly in patients who are hospitalized. Let's shift gears to acyclovir, famciclovir, and valacyclovir. These are guanosine analogs, meaning they resemble the guanosine building block of DNA. They are first activated by a viral enzyme called thymidine kinase, which is present in herpes simplex virus, HSV, and varicella zoster virus, VZV, but not in cytomegalovirus, CMV. Once fully activated, these drugs inhibit viral DNA polymerase and terminate DNA chain elongation. Clinically, they're used for mucocutaneous and genital HSV lesions, HSV encephalitis, and as prophylaxis in immunocompromised patients. Valacyclovir is a prodrug of acyclovir and offers better oral absorption. Famciclovir is preferred for treating herpes zoster. Now you should remember, these drugs won't work against CMV, and they don't eliminate latent virus. Adverse effects include obstructive crystalline nephropathy and acute kidney injury, especially if the patient isn't well hydrated. And when resistance develops, it's usually because of a mutated viral thymidine kinase. Let's finish with ganciclovir, which is another guanosine analog. It's activated differently though, first by a CMV-specific kinase, and then by cellular enzymes to its triphosphate form. It preferentially inhibits CMV DNA polymerase. This drug is especially useful in immunocompromised patients with CMV infections. Its prodrug form, valganciclovir, has better oral bioavailability. But beware, side effects include myelosuppression, such as low white blood cells and platelets, along with kidney toxicity. Ganciclovir is more toxic to human cells than acyclovir. And resistance happens when the viral kinase mutates. Wow, that's a lot of critical info, but you're doing great. Let's begin with foscarnet. This drug acts as a viral DNA and RNA polymerase inhibitor, and it also inhibits HIV reverse transcriptase. What makes it unique is that it binds to the pyrophosphate binding site of the enzyme, and unlike many other antivirals, it does not require activation by kinases. Just remember, foscarnet is a pyrophosphate analog. Clinically, it's used to treat CMV retinitis in immunocompromised patients when ganciclovir doesn't work, and it's also useful against acyclovir-resistant HSV. However, side effects include nephrotoxicity and several electrolyte imbalances, which can even lead to seizures. And when resistance occurs, it's usually due to a mutated DNA polymerase. Now let's talk about cidofovir, another powerful antiviral. Like foscarnet, cidofovir doesn't need viral kinase activation, it directly inhibits viral DNA polymerase. It's commonly used to treat CMV retinitis in immunocompromised individuals and is known for its long half-life, which makes dosing more convenient. But you should remember, it's nephrotoxic too, so it's typically given along with probenecid and 4-saline to reduce this risk. And again, resistance usually happens due to mutations in the viral DNA polymerase gene. Are you following me so far? Good, because now let's move into HIV therapy, which we often call antiretroviral therapy or ART. This therapy is typically started right after an HIV diagnosis, and it's especially important for those with AIDS-defining illnesses, low CD4+ counts below 500 cells per cubic millimeter, or a high viral load. The standard regimen includes 3 drugs to prevent resistance, usually 2 NRTIs, and ideally, an integrase inhibitor. Most ARTs work against both HIV-1 and HIV-2, but keep in mind that NNRTIs and enfuvirtide do not work against HIV-2, and, it is worth remembering tenofovir plus emtricitabine can be administered as pre-exposure prophylaxis of HIV. Now let's dig into the drug classes, starting with NRTIs, or nucleoside reverse transcriptase inhibitors. These include abacavir, emtricitabine, lamivudine, tenofovir, and zidovudine, also known as AZT. These drugs work by competitively inhibiting nucleotide binding to reverse transcriptase, and they stop the DNA chain from growing because they lack a 3' hydroxyl group. Among them, tenofovir is actually a nucleotide, while the rest are nucleosides, and they all need to be phosphorylated to become active. For example, zidovudine can be used during pregnancy or for general prophylaxis to reduce the risk of HIV transmission to the fetus. Adverse effects include myelosuppression, which can often be managed with G-CSF and erythropoietin, and there's also nephrotoxicity. Now pay attention, abacavir must be avoided in patients with the HLA-B*5701 mutation, as it significantly increases the risk of a life-threatening hypersensitivity reaction. Now let's shift to the NNRTIs, or non-nucleoside reverse transcriptase inhibitors. These include doravirine, efavirenz, and rilpivirine. They bind to reverse transcriptase at a completely different site from the NRTIs, and they don't need to be phosphorylated to become active. Plus, they don't compete with nucleotides. Their common side effects include rash and hepatotoxicity, while efavirenz is known for causing vivid dreams and other CNS symptoms. Let's talk about integrase strand transfer inhibitors, often just called integrase inhibitors. Drugs in this class include bictegravir and dolutegravir. They prevent the HIV genome from integrating into the host's DNA by reversibly inhibiting the integrase enzyme. But you should know, they can cause an increase in creatine kinase and may lead to weight gain. That wraps up another critical section. You're doing an excellent job keeping up. Would you like to continue with protease inhibitors? Let's break down the last part of HIV therapy, focusing on protease inhibitors, entry inhibitors, and the big picture of how these drugs work across the HIV life cycle. First up, we have the protease inhibitors, which include atazanavir, darunavir, lopinavir, and ritonavir. These drugs work by preventing the maturation of new HIV virions. Here's how. HIV-1 protease, which is encoded by the POL gene, normally cleaves the long polypeptide chains produced from HIV mRNA into their final, functional proteins. Without this cleavage, the virus can't mature, and it stays non-infectious. So in a way, protease inhibitors trap HIV in an immature form. You might like this mnemonic: never, never, tease a protease, because all the drugs in this class end in never. Now listen carefully. All protease inhibitors require boosting, and this is usually done with either ritonavir or cobicistat. Ritonavir itself is a protease inhibitor, but it's mainly used to inhibit cytochrome P450, helping increase the concentration of the other drugs. Just a heads up, rifampin, which is a strong CYP and UGT inducer, will lower protease inhibitor levels, so we use rifabutin instead when co-infection with tuberculosis needs to be treated. But there are some downsides. These drugs can cause hyperglycemia, nausea, and diarrhea. So while they're powerful, they're not always easy on the gut. Now let's move on to entry inhibitors. First, there's enfuvirtide, which binds to GP41, a glycoprotein on the viral envelope. By doing this, enfuvirtide blocks the fusion between the virus and the host cell membrane. Just think, enfuvirtide inhibits fusion. However, it's given by injection, and patients often get skin reactions at the site. The second entry inhibitor is maraviroc, and this one works a little differently. Instead of targeting the virus, it binds to CCR5, a coreceptor on the surface of T cells and monocytes. This prevents the virus from docking onto GP120, another glycoprotein necessary for entry. You should remember, maraviroc inhibits docking. Now let's zoom out and talk about the full HIV replication cycle, and where these drugs act. When HIV approaches a CD4 plus T cell, the process begins with attachment, which is blocked by maraviroc. Next comes fusion, which is stopped by enfuvirtide. After entry, the virus uncoats and releases its RNA. Then comes reverse transcription, which is targeted by NRTIs like abacavir, emtricitabine, lamivudine, tenofovir, and zidovudine, and also by NNRTIs like efavirenz and nevirapine. Once the viral DNA is formed, it must be integrated into the host genome. This is where integrase inhibitors like cabotegravir, bictegravir, dolutegravir, and raltegravir step in. After integration, the cell transcribes and translates the viral proteins, which must then be cleaved or processed by HIV protease for the new virions to mature. This final step is where the protease inhibitors we just discussed come into play: atazanavir, darunavir, fosamprenavir, indinavir, lopinavir, ritonavir, and sequinavir all act here. And finally, don't forget, ritonavir and cobicistat are not just drugs, they're also boosters, helping maintain effective levels of these powerful agents. You've just walked through the entire HIV life cycle and how modern medications attack it at every stage. Now that's impressive. Are you ready? Let's dive into hepatitis C therapy, disinfection and sterilization, and some important antimicrobials to avoid in pregnancy. We'll start with chronic hepatitis C treatment. It's no longer a one-size-fits-all approach. Instead, it's managed using multi-drug regimens that target specific steps in the HCV replication cycle, and these steps are carried out by HCV-encoded non-structural proteins. Now listen carefully, because each drug class focuses on a different target. First, we have the NS5A inhibitors, like elbasvir, ledipasvir, pibrentasvir, and velpatasvir. These drugs inhibit NS5A, which is a viral phosphoprotein playing a critical role in RNA replication. Although the exact mechanism isn't fully understood, we do know they work well. But like many medications, they can cause headaches and diarrhea. Next up, the NS5B inhibitors, and a well-known one is sofosbuvir. This drug targets NS5B, which is an RNA-dependent RNA polymerase, and it acts as a chain terminator, meaning it stops the virus from copying its RNA. The end result? No viral RNA replication. But it may cause fatigue and headaches. Now let's talk about the NS3/4A inhibitors, like glecaprevir and grazoprevir. These drugs inhibit NS3/4A, a viral protease that the virus needs to replicate. Without it, replication stalls. The most common side effects here are also headache and fatigue. You should remember this. Sometimes, ribavirin is used as an alternative. It works by inhibiting guanine nucleotide synthesis, specifically by blocking IMP dehydrogenase. But beware, it's a severe teratogen and can cause hemolytic anemia. Now, are you following me? Because we're moving on to disinfection and sterilization, a key part of infection control. The goal of disinfection is to reduce pathogenic organisms to safe levels, while sterilization goes a step further to inactivate all microbes, including hardy spores. Let's talk methods. Autoclaving uses pressurized steam at temperatures above 120 degrees Celsius, and it's effective against most microbes, though prion may survive. Alcohols, like ethanol, denature proteins and disrupt cell membranes. Chlorhexidine also hits membranes but works by coagulating cell contents. Chlorine is powerful, it both oxidizes and denatures proteins. Then there's ethylene oxide, an alkylating agent, and hydrogen peroxide, which kills through free radical oxidation. Iodine and iodophores work by halogenating DNA, RNA, and proteins, and may even be sporicidal. Finally, quaternary amines impair the cell membrane's permeability. And yes, those marked with a superscript, like autoclave, chlorine, ethylene oxide, hydrogen peroxide, and iodine, are indeed sporicidal. Now listen carefully, some drugs are strictly avoided in pregnancy because of serious side effects. For example, sulfonamides can cause kernicterus, which is brain damage from bilirubin buildup in newborns. Aminoglycosides are ototoxic, meaning they can damage the baby's hearing. Fluoroquinolones can hurt cartilage development, and clarithromycin is straight-up embryotoxic. Tetracyclines are infamous for discolored teeth and bone growth inhibition. Ribavirin and griseofulvin are both teratogenic, and chloramphenicol can cause gray baby syndrome, a life-threatening condition. So here's a helpful phrase to remember: safe children take really good care. That's for sulfonamides, chloramphenicol, tetracyclines, ribavirin, griseofulvin, and clarithromycin, drugs you should never use in pregnancy.